So this is just about right. Important portions which are frequently asked. So I am going to concentrate on the frequently asked questions for your theory. So practical revision as such is totally different. Maybe we'll touch upon some areas which are again asked for your Viva and for the practical exams, right? So today we are going to cover two topics, that is hematology and clinical pathology. But I wish to say something in general. So whichever the topic, paper one, we have hematology and clinical pathology, not cytology, clinical pathology. And paper two, we have the entire systemic pathology. But, some portions definitely overlap. So some areas like tuberculosis, pneumonia, meningitis, or those things can be asked in both the papers. So that's the most important thing. So don't go to your exam hall thinking that only these portions or these chapters need to be studied for paper one, like that. So try to complete your pathology revision before paper one itself, because see, all are important and there may be overlapping questions. So that is one thing. And when you write a pathology answer sheet, the most important thing is that just write only the salient features. So we don't need large essays, like large something like stories. We need bullet points. Okay, so how you answer is also very important. Just writing the salient features like 1, 2, 3, 4, or putting bullets and writing short sentences. Because pathology is always, it's a truth. So we can't just bluff on truth. So just write the points, put bullet points, write the points. Wherever possible, draw tables as well as flowcharts, and also pictures. So we have written on the top of the question paper itself, draw diagrams wherever necessary. So that's not simply written. That's because we need more of pictures. So always for your exam, take your pencil, a few color pencils, especially the Eucin and hematoxylin pencil, and of course a bangle also, to put a ring, to put a round thing, and you can draw anything inside that. That picture need not be beautiful, but whatever is there in your mind, you should draw it and label. So any picture is not complete without labeling. So I'll repeat again. So just the bullet points, like salient features is points only, then pictures, flowcharts, tables, especially when pathogenesis is asked. That is one part of any question. So always if you write that as a flow chart, so that will be very, very impressive, and you'll get more marks, because the teacher or the evaluator will be knowing that, okay, oh, this student knows something about the pathogenesis. So that is in general about pathology. So now coming to my areas, which I'm going to cover today. So that is hematology and clinical pathology. So we'll just deal with hematology first. Uh, you know, we have three cells, the most important. So they are hematology is divided into three portions: the RBC disorders, WBC disorders, and the platelet disorders, or the bleeding disorders. And in RBC disorders, the most important topic is, of course, anemia. So anything in pathology, one thing you should learn first is the definition for any entity, any disease, except for the systemic pathology and for the tumors. There is definition in hematology as well as in general pathology. So what is the definition of anemia? That you have to learn. The next thing to be known about such entities, especially the hematological disorders, is the classification. How do you classify anemias? So that is again important. So the classification is usually based on the cause. But in RBC disorders, the classification is mostly based on the type of RBC, or the abnormality that happens to the RBC. So whether they are smaller, or whether they are bigger, or whether they are fragmented. So like that. So we have the most common anemias, which you should know: deficiency anemia, the megaloblastic anemias, and the hemolytic anemias together. And among the hemolytic anemias, the three anemias you should definitely learn. You there must know or must learn anemias are the thalassemias, the sickle cell anemias, and a little bit of autoimmune hemolytic anemias. So these are the three anemias you must learn completely. See, others are important for the the MCQs. The MCQ part, anything can be asked. So you should have an overall idea. So I forgot to tell you the disclaimer at the start of my class. See, all these are the frequently asked questions which I am going to tell you. That doesn't mean that in a question paper, like anybody can ask anything from infrequent questions as well. Okay. So coming back to anemias. So anemia, usually they can be asked as essay questions. So you must have seen history, the clinical essays, the history-based essays. So they will be giving a history of a female or a male, usually a female they give for iron deficiency anemia who's having menorrhagia and pallor, etc. So the symptoms are almost the same for all these, like glossitis, easy fatigability, breathlessness. These are the findings given with pallor. On examination, she was pale. And then they will be giving the parameters, the blood parameters. So that is the most important part of that essay. So you should look at that parameters. The hemoglobin is always low. Now, the most important indices, they are the ones which will lead you to the diagnosis, like MCV, MCH, MCHC. So look at them very carefully. And if the MCV is less, usually less than 70, so that's what we usually give for an exam question. And if it's less than 70 or in the 70 or less than 70, like 68, 64, etc. And MCHC is also reduced. You should always think of a hypochromic microcytic anemia. And so the commonest cause, and with that history, it's usually an iron deficiency anemia. And the subsequent, the other sub-questions of that essay would be what is the uh, pathogenesis or etiopathogenesis. So it has two components. Always remember word etiopathogenesis has two components. So you should write about the etiology first. So you know what are the causes of, I'm not going into the details of any of these because we don't have time for that. So what are the common causes of iron deficiency anemia? So it is iron deficiency. So what are causes? So it could be due to a bleeding as well as it could be due to iron deficiency. So you just write the common causes of bleeding that can cause iron deficiency in iron, and also the other causes of malnutrition, etc. So that is about the etiopathy. Now coming to pathogenesis, how the cause brings about the disease. So that is what you should describe in that part, pathogenesis, how the deficiency of iron leads to this hyperchromic microcytic anemia. So that you can write. Another part is the next sub heading should be the clinical features. So this is again applicable. So in general, I'm telling you, not just about anemias, whether it is leukemia, whether it is bleeding disorder, whether it is something else, any disease in pathology when it is asked. So these are the headings you should always remember. So first write about the clinical features. So what is the age distribution? What is the sex distribution? And what are the signs and symptoms? That comes in the clinical features. And then you write, like, if you have a specific question as what is the etiopathogenesis, then you need not write about the clinical features. But if you have a question like iron deficiency anemia, it is a 6 marks question, then these are the subheadings to be written. Okay, you write the clinical features, then the etiopathogenesis, and then comes the major part. That is for the pathology paper. This is a pathology paper. This is not a medicine paper. So you should write what is a pathology. And in hematology, the pathology means it should start from the lab investigations. So these all actually comes under the investigations part. Okay. So investigation. So where do you start for any hematological disorder, whether it is anemia or a leukemia or any blood disorder as such, we start with the blood routine. So you have to write a heading as investigations, and then you should write about the CBC, the complete blood count And you know what all comes under, like when a patient comes to a hospital with this pallor or a suspected anemia case, you will be ordering some investigations. So you can think in that terms. If you don't remember your textbook, you can write like that. So you, for anemias especially, you have to write the hemoglobin, the total count, the differential count, the ESR, and then the RBC indices. The RBC count, the MCV, the mean corpuscular volume, the MCH, the MCHC, and the red cell distribution width also, because that is also important, because in iron deficiency anemia, the RDW is always increased. Okay, write that. So that much is about the lab counts, investigations. Then what? The peripheral smear about the blood. In the pathology lab, what is the other investigation done is always a blood picture. You can write either a peripheral smear or you can write a blood picture. And then you have to draw the picture of hyperchromic microcytic anemia and write about what are the different kinds of cells. You know, iron deficiency anemia is the anemia which shows the maximum anisopoikilocytosis. What does it mean? Change in size and shape. That is anisopoikilocytosis. So you describe what are the different different shapes of RBCs that can be seen in iron deficiency anemia. Draw a picture and label those elongated cells, the pencil-shaped cells, the smaller microcytes, etc. Okay. So, and then the central pallor will be increased, and that is severe hypochromia. You label that, and occasional target cells also can be seen. So once you label that, you'll so that itself makes us think that you know the answer. Okay, and now that's not enough for an iron deficiency anemia. So the next thing you can do is we want to prove that it is iron deficiency. So we need to do some biochemical investigations also. So that is iron studies. We go for serum ferritin, total iron, iron binding capacity, and the transferrin saturation. So all these have to be written in your answer sheet. So all these will be reduced. All will be reduced in except the total iron binding capacity, which is increased. The others will be reduced in iron deficiency anemia. And finally, in any hematological disorder, what is the investigation done? The invasive procedure, that's a bone marrow study. So a bone marrow examination will also show reduced or absent iron stores. So with that, so that's how you should write any answer. So this is just an example. I cannot teach you all the answers. So what is the other anemia always ask for your essay as an essay question? So that is megaloblastic anemia. But there, what will be the difference in the indices? It is in the mean corpuscular volume. So the hemoglobin will be low, but the MCV will always be high. It will always be 100 or more than 100. Actually, if you see 120, that means it is diagnostic of a megaloblastic anemia. But for your theory, we usually give 100 or more than 100 MCV. So when you see that, look at the MCV, and the symptoms may be like even glove and stocking anesthesia, because peripheral neuropathy is very common in megaloblastic anemia. So they may add a history of glove and stocking anesthesia for megaloblastic anemia, but not always. So sometimes they'll just add glossitis for, as I said, only pallor, shortness of breath, etc. But if you have a glove and stroking anesthesia also, that means they are hinting towards a megaloblastic anemia. And now when you write about megaloblastic anemia, so you know the name is megaloblastic anemia, but you are not going to see megaloblast in the peripheral smear. So that is a mistake which is frequently done by the undergraduate students, frequently written. See, megaloblasts are seen in bone marrow. They are seen only in the bone marrow. What do you see in the peripheral smear of a megaloblastic anemia? Because the MCV is very high means we'll see macrocytes. So the peripheral smear picture of a megaloblastic anemia is a macrocytic anemia. So always remember that. So when you draw the picture, draw the peripheral smear and draw a macrocyte which usually lacks a central pallor, and it will be a large cell, much larger than a small lymphocyte. So, and what else do you see in a case of megaloblastic anemia in the peripheral blood picture? We'll always see a hyper-segmented neutrophil, a neutrophil with 5 or more than 5 lobes. That is hyper-segmented neutrophil. So, if you draw a macrocyte and you draw a hyper-segmented neutrophil and label that, so that is enough for a megaloblastic anemia. You need not draw a megaloblast of the bone marrow for a megaloblastic anemia essay, because the other findings, as I said, for the iron deficiency anemia, we should start from the hemoglobin. You should write about all the indices. Then you come to the peripheral smear. I just told you, macrocytic with hypersegmented neutrophils. And what you see in the bone marrow? So this is one anemia where a bone marrow study is absolutely indicated for confirmation of the diagnosis, if we are going for a bone marrow study and not for biochemical investigations. So, because bone marrow will reveal the presence of megaloblast, which are very large erythroblasts. All right. But again, for confirmation, what do we need? We need to demonstrate that there is deficiency of the two things. What are the two nutrients that can cause megaloblastic anemia? Either a vitamin B12 deficiency or a folic acid deficiency. So in the biochemical investigation subheading, you should write there will be deficiency of either vitamin B12 or folate. Okay, red cell folate assay will show a reduced red cell folate and vitamin B12 and or so usually like you should write vitamin B12 will be reduced or folic acid folate will be reduced. So that's how you should write. And what are the other investigations to be done in a megaloblastic anemia? So these are the, you need not always write about the treatment part. So again, just for like the hematology as a whole, I'm repeating. So you should write the clinical features. You should know the etiopathogenesis again, how these megaloblasts are formed. That is very important. You have to read about that. So etiopathogenesis, what's the cause? I just told you, deficiency of vitamin B12 or folic acid. Then the pathogenesis, how these megaloblasts are formed because of the lack of maturation. DNA, so it is a DNA abnormality. Then what? The investigations, the blood picture, the counts, the peripheral smear findings, and the bone marrow findings, and finally the biochemical investigations and other serological investigations. Another serological investigation which is always very important in case of megaloblastic anemia is serum LDH, which is always very high in megaloblastic anemias. Okay, so that's all about the two anemias which are always asked, two nutritional anemias. Now, on the deficiencies. Now, coming to hemolytic anemia, one question always asked is the thalassemia. Thalassemia can always be asked as either an essay question or a 6 marks question. So, beta thalassemia major, you should know the subheadings, just what I told you. So, what is it? What is the etiology? What is the pathogenesis? What are the investigations to be done? What is the blood picture? And how do you confirm the diagnosis? So, how do you confirm any this hemoglobinopathies? By doing a hemoglobin electrophoresis. So that answer must be there in the investigation part of these thalassemia or sickle cell anemia. Sickle cell anemia also can be asked as a essay question. We have seen questions asked, but not as frequent as the three which I just mentioned, but it can be asked. So read about sickle cell anemia also. So the history usually given is again a tribal presenting with failure to thrive, anemia, jaundice. So that is one thing which with which you should let that answer should click your mind. That is anemia with jaundice. So that means it's a hemolytic anemia. So sickle cell anemia like this, you can have, as I said, a history of a tribal inhabitant with failure to thrive, loss of weight, and severe anemia and jaundice with a family history also. Then you should consider sickle cell anemia. And sickle cell anemia, another point they can give is about pains. So leg pains because of the microinfarcts, that bone pains can be given in the history for sickle cell anemia. So these are the four RBC disorders which you should definitely read in detail. The rest, there are other things which can be asked as short notes. So let me share the screen so that you get familiarized with those findings. Second. Yeah. Is it visible? Can you see the screen?
Ma'am, yes, ma'am.
കാണാലോ അല്ലേ?
It's visible, ma'am.
Okay, fine.
Ah.
So this is hypochromic microcytic anemia. So can you see those small cells with the maximum central pallor? You're just seeing a rim of the cytoplasm. The entire cells have become so pale. So the central pallor is much more than 1/3. So 1/3 is the normal. So this is almost occupying the entire cell. That's why it's called a hyperchromic microcytic anemia. And you can see these kind of pencil-shaped cells, the elongated cells with one end pointed. So always label pencil-shaped cell for an iron deficiency anemia. This is what I just mentioned as a macrocytic anemia. So see the macrocytes, very large cells, much larger than the other RBCs. And you're not seeing the central pallor as before, right? So that is how we identify a macrocyte. And what are you seeing here? This is the hypersegmented neutrophil with 1, 2, 3, 4, 5, 6, or this is 7 lobes, in fact. So when you see, for us pathologists, no, when we see a macrocyte along with a 7-lobed neutrophil, that means it is going to be a megaloblastic anemia. Now, so that was I mentioned about two anemias. So this is again another kind of hemolytic anemia, which I am about to tell you. So this is microangiopathic hemolytic anemia. So what are you seeing here? Fragmented cells. Can you see those small fragmented cells? So that is why it is called a microangiopathic, because when these cells, no, this is intravascular hemolysis. This kind of hemolysis occurs intravascular location, not an extravascular location. So these cells become small and fragmented, and these kind of fragmented cells are the hallmark of a microangiopathic hemolytic anemia. So you can get a question as microangiopathic hemolytic anemia. Just 1 second. Okay, I'll have a glass of water. Okay. So these fragmented cells, okay, these fragmented cells can be seen in 3 conditions. You should know this microangiopathic hemolytic anemia in our common clinical scenario. So the most important condition is DIC, okay? Disseminated intravascular coagulation. Then another scenario is the hemolytic uremic syndrome, HUS. And another entity is the TTP, that is thrombotic thrombocytopenic purpura. So for you undergraduates, always learn these 3 entities. So microangiopathic hemolytic anemia is seen in HUS, TTP, and also in DIC. So DIC is a very common clinical, very serious clinical conditions which can even be fatal without a prompt diagnosis and proper management. So MAHA can also be asked. So usually this microangiopathic hemolytic anemia, because of the pathogenesis, it's always associated with thrombocytopenia also. So DIC is also a question for you, a 4 marks question, usually a 4 marks question. So learn about MAHA, DIC. The others you know that can occur in HUS as well as TTP, but disseminated intravascular coagulation or DIC, you should know what are the common causes, what are the investigations, what do you see in the blood picture, what do you see in the biochemical investigations? How do you confirm the diagnosis of a disseminated intravascular coagulation by an elevated FDP, fibrin degradation products? Okay, so these are the things, and the other coagulation parameters will also be increased, like PT, APTT. Okay, so it is considered as it comes under the leading disorders. So that is microangiopathic hemolytic anemia. Remember the three entities. I'm repeating: DIC, HUS, TTP, and learn more in detail about DIC. Now, sickle cell. Okay, again, you have to draw these sickle cells. So the sickle shaped cells usually like won't be seen in plenty. So you will just see these leaf-like, the holy leaf-like cells in the peripheral sphere. But after doing a sickling test with sodium metabisulfate, they form those sickles as well. Okay, so sickle cell anemia, again, you know what is the abnormality when you do what is substituted. So what is the substitution in the hemoglobin beta chain? Okay, and then what is a confirmatory test? Again, it is a hemoglobin electrophoresis. And again, what are the investigations? So it's again an anemia. So it all starts with the hemoglobin, the ESR, the MCV, MCH, MCHC. And the most important part is the blood picture. And one investigation you must write in a case of sickle cell anemia is the sickling test and the HB electrophoresis. These are the two confirmatory tests. So that's how do you come at a diagnosis and how do you confirm? That's how you should write your answer. So that's about RBC disorders. And one more thing to be included is aplastic anemia. Again, aplastic anemia can also be a 4 marks question. So that is again about the causes. So you just learn about the common causes. There is a list of causes, classification of aplastic anemia, starting from idiopathic causes to other genetic causes, like the Fragile X syndrome and all. So you please go through them. We can't go into the finer details, but aplastic anemia. And again, as I said about megaloblastic anemia, aplastic anemia is a word we use for the bone marrow, bone marrow interpretation. So what you see in the peripheral smear of a case of aplastic anemia, it is pancytopenia. So when you write an answer on aplastic anemia, you start with the hemoglobin TC and platelet. So hemoglobin will be low, total count will be low, and the platelet is also low. So that is what is called pancytopenia. All the three lineages are reduced. So when you draw a picture, when you write about the peripheral smear or the blood picture, what will you write? You should write that there is anemia, leukopenia, and thrombocytopenia. That is pancytopenia. And the bone marrow will show mostly fat and less marrow. The marrow will be aplastic or hypoplastic. So that again, that entity is a marrow diagnosis, aplastic anemia, and write about the common causes. So read that also. Then in hemolytic anemias, the areas which are always covered for your MCQs or single response questions, one important area is malaria. Malaria. So what are the malarial parasites and which are the forms of malaria? You know, that is important for your parasitology also. It's the same here. So അതാ പറഞ്ഞത് കുറെ subjects കുറെ like it comes in the same topic comes in different subjects. So whatever you have learned in parasitology, you can apply here in your answer paper in pathology too. Okay, so malaria is one. Then the autoimmune hemolytic anemia, as I just told you. So just learn about what is a warm antibody hemolytic anemia. What is a cold antibody? Just about this, just to know, because when you get a question on MCQ, you should know there are some entities. So IgG is a warm antibody hemolytic anemia, and IgM is a cold antibody hemolytic anemia. So, for example, in SLE, we always get a warm antibody hemolytic anemia. Okay. Then what is Donat-Landsteiner antibody, which is seen in PCH? So that is one entity which is usually covered for your MCQ. paroxysmal cold hemoglobinuria. And the antibody present, it is a Donat Landsteiner antibody. Okay, remember that. So that is one question. Then another question asked is the PNH. That is paroxysmal nocturnal hemoglobinuria. That is one entity. Just understand what is the deficiency that leads to PNH. Just understand what this disease is. Okay. So I think that's enough for RBC disorders. Now we'll come to WBC disorders. You know, we must have taken 5 or 6 hours for WBC disorders. But for you, the most important two topics in WBC disorders, or three topics in WBC disorders. One is, of course, acute leukemia. Second is chronic myeloid leukemia. And the third is multiple myeloma. You cannot come to the exam hall without reading these three. You have to learn and what to learn. Okay, so acute leukemia again asked as a clinical essay. And like your teachers must have taught you how to identify like which is acute leukemia, chronic myeloid leukemia. So you look at the history properly. So if it's a young child coming with generalized or just cervical lymphadenopathy, hepatosplenomegaly, and they will give a blood value as a low hemoglobin, total count nearly 1 lakh or more than 1 lakh, with blast more than 20%, and platelets again less than, or platelet is reduced in any range. It's less than 50,000 or 80,000 or whichever range. If the platelet is reduced, total count is high, and there are 20% blasts, and they have given the history of hepatosplenomegaly with lymphadenopathy, or sometimes they may not give lymphadenopathy. So that is going to be acute leukemia. But if the history is that of a massive splenomegaly, and they give a blood value of low hemoglobin, very high TC, 2 to 3 lakhs, and high platelets also, that means it is going to be a CML. So look at the size of the spleen before jumping into your answer. If they have given it as a massive splenomegaly or a huge spleen, that means the answer is chronic myeloid leukemia. Because once what is your diagnosis is always the first question, sub question under your clinical essay. And if the diagnosis goes wrong, what will be the marks? It will be a big zero. And you are going to lose 10 marks as a whole if you go wrong in this clinical essay. So that is a problem. So read the question again and again, and then only write the answer. Okay, so what do you have to learn about acute leukemia? So you know what are the two types of acute leukemia? The myeloid leukemias as well as the acute lymphoblastic leukemia. You need not write AML or ALL. Acute leukemia is sufficient. So that is sufficient for you for the diagnosis. And then maybe the sub questions asked is, what is the classification of this disease? So you know we have the FAB classification and the WHO classification. You have to learn both. And for AML, there are 8 entities in the FAB classification, and then the WHO classification. Just by heart the WHO classification and write down all the classes of WHO. Again, there are 7 in the WHO classification. And for ALL, it's usually it is 3 in the FAB classification, and again 3 in the WHO classification. But at least for you undergraduates, you should at least write that it is a BALL and TALL. That is B acute lymphoblastic leukemia, and T. You know, we have the B cell origin and the T cell origin. So the classification is very important. The next question is again, what is a lab diagnosis? That is the part in hematology. What is a lab diagnosis? Again, as I said about anemias, you start from the investigations, the CBC, write down the CBC, the hemoglobin total count, the differential count, the platelet count, draw a blood picture, a properly labeled blood picture, and then of course, bone marrow study is very, very important for diagnosis of leukemias. And nowadays, bone marrow is not like absolutely indicated for all cases because we have other newer investigations which we have taught you, like flow cytometry. So if the count is very high in the peripheral blood, a flow cytometry will be sufficient to have the most specific diagnosis of leukemia. But it's not available in all centers, but in smaller hospitals, we'll always do a bone marrow to confirm the diagnosis. And if they ask you to draw and label a myeloblast, so this is how you should draw it. So it is a very large cell with scanty cytoplasm. This, of course, has a little bit cytoplasm, but when you draw like this, a large cell like this with little bit of cytoplasm. And what you draw in the cytoplasm to say that it is a myeloblast? The OR rod. So just draw a pink rod. One or two rods are enough. Don't draw this much because this, no, as labeled, this is an acute promyelocytic leukemia. And what is this cell called, which is always asked for your MCQ? This is a faggot cell. So faggot cell is a cell with too many OR rods. More than 12 OR rods in one cell is called a faggot cell, and that is almost diagnostic of AML M3, acute promyelocytic leukemia, which has a very specific and consistent cytogenetic abnormality, translocation 1517. So the genetic abnormalities in AML is very important. At least learn 4 of them, okay, which we have given you. It's given in all the textbooks. And AML M3 is one leukemia which can always be cured because 100% of cases have this genetic abnormality. And another important feature of AML M3 is that this is the leukemia which always presents as DIC. DIC. And so that is again one MCQ question. So ALL, you should learn the classification. AML, you should learn the classification. You should learn to draw the blast and label them. Okay. So that is how you should write an answer on acute leukemia. And this is how a chronic myeloid leukemia looks like. So this here, as I said, the platelet count will also be increased. The total count will be increased and you will be seeing all the different series of WBCs, not just neutrophils. You will see eosinophilia and basophilia. So that is one characteristic feature of chronic myeloid leukemia, increasing basophils. So basophilia, neutrophilia, eosinophilia, basophilia with increase in platelet count. And as I said, a huge spleen. So the diagnosis is chronic myeloid leukemia. And what else should you know about chronic myeloid leukemia? What else? The cytogenetic abnormality. What is the cytogenetic abnormality? The Philadelphia chromosome. And you should know everything about the Philadelphia chromosome. What is it? What is translocation 922? And how does it cause chronic myeloid leukemia? So that is the pathogenesis of chronic myeloid leukemia, how the translocation happens, how the ABL gets translocated to the BCR locus, and what does that fusion, how does it cause tyrosine kinase activation and proliferation of the WBC. So if you write that as a flowchart, well and good, that's enough. You need not explain much. But the picture you have to label, especially the basophils you have to label, the myelocytes and metamyelocytes you have to label, and the platelets also you have to label. Okay. So that is chronic myeloid leukemia, the two important areas of WBC disorders. Another question always asked is infectious. Okay, sorry for the spelling mistake. It is infectious mononucleosis. Infectious mononucleosis that is caused by which virus? Epstein-Barr virus. And this is the picture of the peripheral smear of IMN. What do you see? These are the cells. You should write this. Atypical lymphocytes. The different shapes, the downy type 1, type 2, type 3 cells. Downy, DOWNEY. You must have heard about that. Now they are in the textbooks describe them only as atypical lymphocytes. So increase in atypical lymphocytes caused by Epstein-Barr virus. The rest you go and learn. What are the investigations? What are the complications? What are the clinical features? I'm sure you must be remembering what your teacher taught you about the clinical features of infectious mononucleosis. Okay. And So that is one, lymphocytosis. You can also get questions on eosinophilia and agranulocytosis. That is again asked. So these are the other questions usually asked, frequently asked in this chapter. Now, another area is plasma cell proliferation, multiple myeloma. This again, you should always draw the picture and label them. Okay, plasma cells. So these are the plasma cells. They have an eccentric nucleus, blue cytoplasm. And they are seen in the bone marrow, not in the peripheral smear. Okay, they proliferate in the bone marrow. So multiple myeloma, again, you should learn what is multiple myeloma. That can be asked as a clinical history-based essay, like an elderly male who presented with renal failure and pathological fracture. So that is the most important history always given for you, or with bone pains, pathological fracture, renal failure, and investigations showed lytic lesions in the bones, in the long bones and skull. And in the skull, the lesions are described as punched out lesions, and lytic lesions in the bone with pathological fracture. And bone marrow, so then they'll ask what is the professional diagnosis. So you can write multiple myeloma, because what are the points in favor of multiple myeloma? Elderly, bone pains, pathological fracture, renal failure. When any of these are given, always know you correlate. And then another hematological investigation they will give you is the ESR. So ESR is usually 120, 150, much above 100. So when that all these together, you should always think of the diagnosis as multiple myeloma. And then you write the etiopathogenesis, again, the investigations. And the most important investigation to be done in case of multiple myeloma is the serum protein electrophoresis. So peripheral smear and bone marrow, absolutely indicated. Serum protein electrophoresis. I told you about hemoglobin electrophoresis for thalassemia. This is serum protein electrophoresis to detect what is known as a monoclonal gammopathy in myeloma, because these plasma cells secrete a myeloma protein, and that myeloma protein, because of the monoclonality of these plasma cells, it's called a monoclonal gammopathy. Okay, we get an M band, in the serum protein electrophoresis. So learn about multiple myeloma also in detail. Okay. So I think I didn't keep any picture on the bleeding disorders. Among the bleeding disorders, the most important two areas which you must learn, one is, of course, ITP, idiopathic. So we don't use the word idiopathic now. It is now called as immune thrombocytopenic purpura. So ITP is an internationally accepted abbreviation. So you can get the question as ITP also. We need not give the full form. ITP, immune thrombocytopenic purpura. Again, you learn everything about ITP, starting from the counts, blood picture. But for any bleeding disorder, the other investigations to be added is always the coagulation profile. So you should write what is the bleeding blood time, what is the clotting time, what is the PT, the prothrombin time, what is the APTT. So these four should always be written: BT, CT, PT, APTT. This much you should write. And for DIC, the FDP, the fibrin degradation products, will also be increased. The others will be reduced. So that is about ITP. You're right. The bleeding time is always prolonged in ITP. So that's the most important part. I mean, investigation. We start the other investigation from the bleeding time. Then the bone marrow finding in ITP, that you should write. Now, hemophilia. So that is the coagulation disorder. So factor 8 deficiency, that point must be there. Now, what are the presentation? How do the patients present? In that case, you can also write, how do we treat those patients? So what are the manifestations, like large joint bleeding or hemarthrosis, etc. Okay, so that can be given for your clinical based MCQ. This is one scenario which we always choose in the MCQ, because they give a child playing in the, like fell in the playground with, he developed a hemarthrosis, etc. So the answer is hemophilia A. And factor 9 causes hemophilia B or Christmas disease. So these are the areas. And then which is the commonest bleeding disorder? It is von Willebrand disorder. VWD, von Willebrand disorder. So, see, some areas are important for your MCQs as well. So, we cannot go into finer details now. Now, let me come to the last part. That is, we'll just rush through. I'm not going to teach you all these things. I'm just telling you these are the topics to be which you must know. You must learn. Okay, they are not just good to know things. These are must know things because these are asked for your practical viva, for your practicals, and for your for paper one. Okay, so what are anticoagulants? Classification of anticoagulants, for which tests they are done. So that is these are the three things you should learn about anticoagulants. Okay, the calcium chelators, EDTA. So many students, even after learning all these, when we ask which is a routine anticoagulant, which is the anticoagulant used for blood routine studies, they'll just keep quiet, keep mum. So EDTA, never forget this, EDTA and its full form. EDTA എന്ന് പറഞ്ഞാൽ പോരാ. You should learn the full form also. Okay. Double oxalate, sodium citrate. Again, one question we always ask is, what is the anticoagulant of choice for ESR? Then you should say that it is trisodium citrate, always ask. Then the next question asked is, what is the ratio? So you should say 1:4. The ESR can be asked as a 4 marks question in your theory paper also. Anticoagulants can be asked as a 6 marks question for your theory paper. So that's how these are important. ESR, I just told you. What is ESR? How is it done? What are the factors affecting ESR? What are the different methods of ESR? Of course, what is the anticoagulant used? And which are the cases, or which are the conditions where ESR is too high, and which are the cases is where the ESR is too low as 0. Okay? So that's ESR is again one area which you should learn. These are the methods. I just told you what are the different methods of ESR. This you have to by heart because these are things important for all the three, practicals, viva, as well as theory. Okay. PCV, another short note. Packed cell volume can be asked in many ways. Some people ask just PCV. Some question papers, it can be asked as hematocrit. It's the same. PCV. So just write about PCV. And what is the anticoagulant of choice for PCV? It is double oxalate. Double oxalate. It is a mixture of ammonium oxalate and potassium oxalate in the ratio 3:2. So what are the different methods of PCV? What is Windrop's method? Okay. Now, another short question that can be asked for your paper one is hemoglobin estimation, methods of hemoglobin estimation. So, you know, there are manual methods, there are automated methods. So, which is the most sensitive method? It is always cyan-met hemoglobin method by the manual method. Automated methods, we get in the automated counter. Okay. Sally's, which you have been taught about Sally's method. The methods you should know. You should read from your records. It's all given in your clip record. You have to learn all these for your paper one. I tell my students always, you start reading from your SDL notebooks as well as your record first, and read the corresponding theory part because they are the most important topics for you. WBC, diluting fluids, very important, especially for the MCQ question and also for your Viva. RBC fluid, platelet fluid, at least you should be able to name it, the resecker fluid, though not the constituents, you should know the name of the fluid. Okay. And one more, this can again be asked, one diluting fluid for eosinophil count, absolute eosinophil count. Diluting fluid used for absolute eosinophil count is Hinkleman solution, or it can be a pilot fluid also, a pilot's fluid. This is another important area this is again one important essay question for you. What are the findings, CSF findings in different types of meningitis? So you should know this table. You have to by heart this table. If you know this table, you'll definitely get 10 marks from that question. Maybe sometimes it can be asked as a 6 marks question as well, maybe in the MCQs, but this cannot be skipped. CSF findings in different different causes of meningitis. Another area which you should learn is the cytological techniques. What is exfoliative cytology? So that is also asked as a short note. Exfoliative cytology is a 4 marks question for you. What is exfoliative cytology? The classical example is the Papinicolau smear. That is the cervical smear. So we take the exfoliated cells by just smearing that area. That is exfoliative cytology. How do we collect the samples? And this is one thing which is often asked, kept for your viva, and we ask questions on that. The air spatula. So these things can be written in your answer paper as well. Okay. How do we prepare the fluids? That is fluid, again, exfoliative cytology, because cells are shed into the fluid collected in the body cavities, like pleural fluid, peritoneal fluid, ascites, etc. Okay. You don't need all these things. Okay. So this is, again, sometimes asked for your viva and for your theory as well. So what is the stain used in cytology for your MCQ? It is a Papinicolau stain. Never forget that, the Papinicolau stain or the PAP stain, PAP stain. This is needed for your systemic pathology also, because when you get a question on carcinoma cervix, you have to write about this Papinicolau smear, which is used for screening and early diagnosis of cervical cancer. So as I said, this is a spelling of Papinicolau, the pap smear. Okay. Then in hematology, another area which is very important is the stain part. What are the Romanowski stain? And you have to know the ingredients of Leishman stain. Without reading about Leishman stain and its ingredients, please don't come to the practical hall. Okay, because when the external examiner asks you what are the ingredients of Leishman stain and you keep quiet, that's over and everything is over by then. Huh? So learn about this Leishman stain. I'm not going to the details. One more important area which is important in the pathology, the lab part of pathology, and paper 1 is processing of biopsies. So what are the steps in tissue processing? That's also asked for your viva, for your practicals, and for your theory as well. So you should know what are the different steps done in a histopathology lab when we receive a tissue sample from the surgical theater. Okay, receipt, labeling, fixation. So what are the fixatives which are used in histopathology? Which are the dehydrating agents? What are the clearing agents? What is paraffin wax? What is its melting point? Then embedding section, staining. And what is the stain used in histopathology? It is H&D, hematoxylin and use. So this flowchart, these steps, very important. Can't skip. Urine analysis, so it's too late. I know 45 minutes or maximum 40 minutes is the concentration or the time, your retention or attention. Okay, sorry, not retention. Retention, അങ്ങനെ ഒരു സാധനമേ ഇല്ലെന്ന് എനിക്കറിയാം. Attention. Okay, I'll just go through the slides to know like these are all important topics when you come for your pathology exam. So Benedict's test can be asked as a theory question. Test for protein, another theory question. So you should write all these, the names of at least the names of these tests and describe one of the tests. And for Benedict's and protein, you have to know the grading also. Fine. Okay. Then test for ketone bodies. That is also important. You should know the procedure, the principle. So for any urine test, the two headings or the two things you must know. What is the principle of the test? What is the procedure. And finally, how do you interpret the test? And if there is a grading, that also. Rothras test, causes of ketonuria. And this is again 6 marks, or sometimes they can even ask as a 10 marks question. That is urinary sediments or urine analysis. So that you have to learn your notes very well. You have to learn to draw all these cast, the cells, then granular cast. These are all asked for your MCQs. What are granular cast? In which condition do you, or what are the urinary sediments seen in a case of nephrotic syndrome? So that's how we ask questions. Fatty cast, cells, epithelial cells. Unorganized sediments are the crystals. The cast are the organized ones. Which are the different types of crystals seen in acid urine, alkaline urine? Their shapes like these. All these. Okay. So that's just a